Welcome to I Married a Urologist. This is a fun and educational show where the doctor's wife discusses all things urology, a taboo subject that will affect 100% of the human race at some point in their lifetime. Join host Madeline Zech Ruiz, the author of I Married a Urologist, who fixes women too, wife of urological surgeon Dr. Henry Ruiz, as she interviews medical experts, patients, and industry professionals who develop solutions for problems with our downstairs plumbing. Madeline lifts the veil to all things urology and helps us learn how to reclaim our quality of life.
Hello everybody, and welcome to I Married a Urologist, keeping your human plumbing healthy. Today we have a very special guest on the show. This is the person who inspired me to write my book, I Married a Urologist. Now, I didn't know anything about urology until I married my husband, who happens to be Dr. Henry Ruiz, who is a reconstructive urologist. And 20 years with this man has given me all kinds of exposure to the world of urology. And what I learned is that I didn't know anything about urology. But through living with him for 20 years and being in our community and serving our community, so many people have approached myself or my husband and had questions about all things urology. So I wrote a book to educate people like myself who were unaware of all the things that can happen with urology. So today, I'd like to welcome my amazing husband, Dr. Henry Ruiz. Welcome, honey.
Thank you. Great to be here.
Thank you for being on the show today. So, a lot of people don't know what a urologist is and what they do or what training they have. So, tell us a little bit about your road to becoming a board-certified reconstructive urologist and what that is exactly.
So in urology and in most surgical subspecialties, it involves taking things out. When you do an operation, you tend to remove something. And in my mind, the way my mind thinks, I was very unappealing. What I enjoyed was fixing things, making them better, and putting back together so that they will work and function even better than they did. So instead of taking things out and violating their anatomy, I tried to put them back together. So reconstructive urology has thought, is very fortunate that we do both in both men and women. We fix things in men and we fix things in women that are actually very intimate parts and very intimate and worrisome conditions. So.
And those intimate body parts, those are the things that we're talking about today, because everybody has one, and they do break, don't they?
Unfortunately, yes.
I think I've heard you say so many times that 100% of the human race at some point in their life will need a urologist.
And that's essentially true. Eventually, I always say it involves also children will need a pediatrician and adults will eventually need a urologist, reconstructive or not, but you'll end up in some urologist's office. And more likely than not, yes, you'll come to see me, whether you're a man or a woman.
And that's the good news, everybody, because if you go see a doctor like Dr. Henry Ruiz here, who is a reconstructive urologist, you may walk in with a problem, but they're going to walk out pretty happy when you're done, aren't they?
Well, that's always the aim, and you're not always completely successful, but in the great majority of the time, you can certainly make them significantly or a lot better than where they came in. So those are usually my own happiest patients, but when they show up, but usually my happiest patients after we get done with them.
Yeah, and then their problems are solved and they can get their quality of life back and get back to doing what they love.
That's right.
So in your practice, what is the difference? How many women and men do you take care of? Because you're a reconstructive urologist, are you more men? Are you more women?
So to clarify, this day and age, when I trained in reconstructive urology, I was very fortunate to train in both male and females. These days, if you want to be a reconstructive urologist, you have to choose either males or females. Very few do both. So in their board certification, especially in the female pelvic medicine side. In my practice, I probably see a little bit more women than men. So it's probably about 65, 40, or sometimes even 50-50. So I'm very fortunate to have that diversity in my practice.
Wow, that's amazing. So let me break it down a little bit further, since you were 60-40 and then 50-50.
Yeah, or 65-45.
Yeah, somewhere in there. Bottom line is, he's seeing all of us all the time. So let's talk about the men first. Why not? So let's get right down to it. When a man calls your office and he needs a urologist, what is the most popular issue in urology of why a man would be needing your services?
So it all depends. If it's a general urological problem, then usually it's the prostate. If it is for a reconstructive urologist, usually it's erectile dysfunction.
Erectile dysfunction, commonly known as ED on the television commercials. So with regards to erectile dysfunction, I know that's a scary word, but don't let it scare you, because there are solutions, right?
Right.
A lot of solutions, aren't there?
Yes.
And more importantly, what I think people don't understand is most men at some point suffer from erectile dysfunction at some point in their life, right?
Yes, there are many different conditions that make it more likely to be to show up at an early age, especially diabetes, obesity, high blood pressure, cardiovascular disease, the same things that plug up arteries in the heart, do the same thing to the arteries in the penis. Age, unfortunately, as we get older, that's one of the things that can happen. So erectile dysfunction becomes much more common at 7th, 8th decades of life. Very prevalent.
And so, talking about erectile dysfunction, what are some of the solutions that you can provide to your patients? What's an array of options that they can have to solve their erectile dysfunction?
So our parent organization, the American Urological Association, provides guidelines for us to use in practice. And in most instances, most patients will be started, if there are no contraindications, on one of the medications. There are 3 or 4 medications that are available now. 2 of them are generic, so they're affordable. Before they would charge $50 or $100 for a pill. So that was prohibitive, especially if the insurance company didn't cover. Most insurance companies did not want to cover that. So in general, you start with the easiest solution first, and you give them instructions on how to take it. And then you bring them back, somewhere in the near future to reevaluate. If they're doing well, then they stay with that treatment modality. Most people are used to taking a pill for headaches, for high blood pressure, and other things. So it's very easy to take a pill for this. If that doesn't work, then it becomes a little bit more cumbersome, but there's still possible to find a solution that include injections, the injections that are directly done on the penis before they embark in having intercourse. There are what is called urethral suppositories. One of the components of the injections is made into a little pellet that can be inserted inside the urethra into the penis. There's something called a vacuum erection device that is a kind of a pump that you place over the penis, and then it forces blood into the penis, and then you put like a ring at the base of the penis not to allow the blood to escape. And lastly, then the ultimate is penile prosthesis. And there's a variety of models that can be used, and the patient gets to choose whatever they think is better for them. Using one of those modalities pretty much virtually everyone can find a way to become functional again.
Right, because erectile dysfunction is just a temporary situation in most cases.
Well, if they seek treatment and they're willing to go through any of these modalities, and yeah, you know, one of these, the things that I just mentioned, will get the patient to work.
There is one that he brought up that I do want to talk about because it certainly got my attention, and that was penile prosthesis. My imagination ran away with me because I couldn't possibly think of what you would stick inside of a penis to make it erect. But over the years of being married to you, I have learned about the penile prosthesis, and honestly, it's amazing. And I wrote a whole chapter on it in the book, and I was lucky enough to be supported by Boston Scientific, their manufacturer of one of the prostheses that you use. So we do have pictures of the devices so you can understand. But are there multiple varieties of penile prosthesis? And here's the question everybody wants to know. Can you make it bigger?
Interesting that you say that, because that's the number one request when a man decides that they want to have a penile prosthesis. Invariably, they will ask me, Doc, and can you give me something bigger than what I have? And the answer is no. We can make you as good as God Almighty, or the same size as God Almighty gave you, but I cannot make it bigger. There's no such thing. In fact, if you force a prosthesis that is bigger than the penis, it will break through, and it's a disaster because it gets infected. And by the breaking through, it breaks actually through and outside the penis, and that immediately gets infected, has to be removed, and then it would be just about impossible to have another one done in the future. So probably the most important part of the whole operation is properly sizing the penis and the prosthesis. And we have essentially a infinite number of sizes that we can use. There are several different types. What we call the Cadillac, the best model, is a 3-piece penile prosthesis that is all based on hydraulics. You insert the 2 cylinders inside the penis. There's a pump that is the activating part of the prosthesis that is pressed either on the right or left side of the hemiscrotum, depending on what your dominant side is. And then there's a reservoir that is going inside the belly. That's where the pressure generated balloon is that provides the fluid. There are 2, and that provides the best erection, and then it appears the most natural once the prosthesis is deflated. There's a 2-component prosthesis that is used in some patients that are not because of surgical procedures in the past and so on. Are not candidate for the 3-piece because you can't really go into the abdomen. And there are those semi-rigid prostheses, which are essentially 2 rods that are placed inside the penis. That is, in the penis is semi-erected at all times. That's usually reserved by one patient's choice. Some men just prefer that. And the second one and most common one is in patients who have some weakness in their hands. They've had a stroke or all too old to really activate the device. When that's the case, then the semi-rigid is quite functional and is very satisfactory.
And are your patients really happy with these devices in general?
So if you look at the literature of the studies done looking at the satisfaction rate, and the most important satisfaction rate is from the partners of the patients with the prosthesis, right? That should be what counts, not what the man says, but what the partner says. And it's about 95% of the patients, 90 to 95% of the partners of the parent are satisfied and would recommend it to friends and so on. So it's incredibly high. So yes, it works well. The life expectancy of the prosthesis is about 10 years. So at the end of 10 years, it can break down, and then you can just take that one out and put another one in. The complications rate is low. It's 2% infection rate. Bleeding we can control very easily, and the fact that it's man-made, so it can break before the 10 years are out. So just fix it. The problem is infection. If it's an infection, And and the patient is not, doesn't come in to be seen early on in the infection, then the only solution is removing that and then putting another wire back in after the infection sets in is just really, really hard and sometimes impossible depending on the degree of the infection. If they come in early, then you can remove the prosthesis if there's no gross signs of infection, like pus or something like that. And you can clean everything, irrigate out, and then you put the 2 semi-rigid cylinders, so that doesn't allow the corpora to just obliterate by the infection. And at a later date, when everything settles down, you can go back and put another inflatable one. Or a lot of the patients like the 2 rods and decide that that's what they want to keep. So that's one of the newest approach that we have. In the past, you came in with an infection, just removed it, and then you have to deal with the consequences of that later.
So what I heard you say in all of that technical jargon is work with your urologist and communicate often and regularly. And if you have an infection with this amazing device, which is low percentage rate, call your doctor right away and get on top of it.
It's like, if you feel new onset of pain, redness, swelling in the penis, scrotum, we need to know that right away.
Pick up the phone.
Yeah, right away. Or coming into the office without an appointment.
Just show up. They'll help you.
Yeah.
Okay, so that kind of leads me to the next subject. Now that we're loaded for bear and ready to go with our new penile prosthesis, what happens when you have a lack of desire? Now, lack of desire, we're all watch TV, we see all these commercials. There's a low T and get your desire back. First of all, are those commercials right? Does that stuff work? And 2, is low testosterone or lack of desire a real issue for men and women?
So yes, it happens in both men and women, and some of the latest studies shows that is as common or more common in women than is in men. And it certainly is, especially in women after menopause. In men, as we get older, we've seen an epidemic of men in their 30s and 40s that come in with essentially low testosterone, and signs and symptoms of that, which is one of them is lack of desire, or lack of libido, decreased energy, increased irritability. They just feel pretty crappy. They gain weight, hard to get rid of the weight. And I saw a patient today, typical symptoms, and we checked them a few days ago and came back for the results. It's no surprise. And in that scenario, then if you replace the testosterone, then all those symptoms go away, and it provides what we call a sense of well-being. We make them happy, and their libido is restored. Their energy level goes through the roof. They start working out again. They start being pissy all the time, because that's one of the symptoms is that. So
when they're a little too much energy.
No. When they have too little energy, when they have the symptoms, that's one of them is that they're in pretty bad mood all the time. So ladies, if your man is
grumpy
like that, may I want to have his testosterone checked.
Have him call my husband.
Yeah. So very effective treatment. Also the same thing with women. And that's a little bit more complex, and it's a newer modality, and we're learning more and more about women. It's female sexual dysfunction is now a very well-researched, or in the process of being a well-researched condition, but they're still in the infancy. We're learning much more. Hormonal replacement therapy greatly improves their symptoms. And the treatment also can be low-dose testosterone. That you need to be really careful then dose it correctly and check it, so that too much in women, testosterone makes them, again, the difference is very aggressive. Their voices change, they get facial hair, they get hair in places that they don't like. And I recently saw the wife of a physician, colleague of mine, the husband was treating the wife, and he's not a urologist. And she came in to see me, and we checked her levels, and I said, no wonder. I said, how is it that you just have him just kill him? He goes, I want to so many times. for that. So I called him and I told him, hey, stick to your specialty.
Yeah.
You're not helping yourself with this. And so we redosed her and did a few things, and then I saw her on follow-up, and the first thing she comes, oh my God, I feel so much better, and I don't want to kill him anymore. So
that's hilarious.
That true story, by the way, that happened. So.
Yeah, that's the extreme, and then you can have the other extreme where you're so not interested in your partner anymore, you actually think you want a divorce.
Yeah, I mean, in both extremes. So that's the lack of desire. Again, it can happen in what we call premenopausal women before menopause, but it's much more common in postmenopausal. There is a counter, believe it or not, a medication that is called the female Viagra that treats this condition that is available in the market. The results are kind of mixed, but some patients swear by it. Others, it doesn't affect them, but there is such a thing.
What's in it?
It's not the same in component. In fact, so that you know, Viagra has been tried in all the other medications in women. It doesn't work in women because the mechanism of action is totally different. In women, so in men, the medications increase blood flow to the penis because that's usually the problem. In women, it's here, so it regulates brain function, those areas of the brain that are involved in arousal and sexual function.
You know, I wrote a chapter that mentions some of these details, and it's genitourinary symptoms of menopause. And during all my research, what I learned is that we haven't even scratched the surface about treating women's sexual desires, women's response to estrogen and the purpose of estrogen all throughout a woman's body, our estrogen receptors. And that's a chapter, by the way, when I interviewed him for my book so I could learn all things urology. And when I asked about
multiple times.
Over pancakes at IHOP. And when I asked him about the subject of genitourinary symptoms of menopause, he suggested it. And I said, okay, tell me all about it. And he said, no, you research this one on your own. And when you're done, I'll read the chapter. And how did I do on that chapter?
Extremely well.
Yeah, and I learned so much. I'm glad I didn't ask him because I read for days and I was so surprised to learn the role of estrogen and the role of estrogen receptors and testosterone, of course, and how a woman's body functions from head to toe with all of that. It's like one big system, and we didn't realize that.
And when you go through menopause, all that goes away.
All of it goes away.
And the vaginal lining, vaginal structures are 100% dependent on estrogens. So when that goes away, then things begin to break down, both physically and mentally.
And isn't it true that, and this is something I learned, the orgasm occurs 99% in the brain, right? And then the body just enjoys the results.
So there's a very high, mind to body connection in there. So yeah, there has to be that connection. I'm not sure what the percentages are, but there has to be both. If there isn't, nothing is going to happen.
So ladies, concentrate. It matters. And take your estrogen. Okay, so since we're on the ladies, I'm just going to go one more for the ladies. And this is something that affects all women. It's, again, part of genitourinary symptoms of menopause and after childbirth and old age, and that's incontinence.
Although they a lot of times are related, but they're two separate conditions. So women, as they get, especially after menopause, is incontinence and bladder prolapse can coexist. But you can have certainly bladder prolapse and not have the genital symptom of menopause. You don't have to have both, but they can coexist. And incontinence is the main cause is childbirth, especially if you start early, if you have multiple babies, if you have had surgeries, C-sections, any hysterectomies, anything like that, and certainly after menopause, that the incidence go dramatically higher after that. And luckily these days women are much more educated, and they're more likely to come for help or assistance than in the past. In the past, I was so embarrassing for the patients to talk to the doctor and tell them that was going on. We have about 37 million women with incontinence here, and one of the subjects that is really could be related is also fecal incontinence. You can have both, and that's a much worse condition. And that's about 20 million women in this country have both.
Mm-hmm. From
Stress
childbirth?
incontinence, well, childbirth, also surgeries, other conditions of the bowel that cause the same issue. Obesity is one of the factors, but mostly for stress urinary incontinence for that. So the key is that there are very effective treatments, but the longer you wait, the choices become less and less. If you act early, then by all means, the choices tend to be less invasive and can certainly be curative.
And so, as a urologist, does anything shock you anymore that a patient talks about with regards to their human plumbing?
After 25 years of this, very few things surprise me anymore.
Right?
Yeah, it makes it for an interesting day.
Have you heard it all?
Well, probably not, but I've heard a lot.
Yeah, you see, everybody, you cannot shock a urologist at all. They have heard it all, they've seen it all, they've fixed it all, and all you got to do is pick up the phone and call the urologist office or get a referral, right? If you go to the gynecologist, you can ask for a referral, right?
That's right. And one of the most important things that I tell my patients is because a lot of them come in and think that they're the only one with that condition. And you should see their faces when they say, oh, yeah, that's actually very common. And they say, really? I said, oh, yeah, I'm sorry to tell you, but you're not that special. I have a lot of patients with that same condition. And actually it's a relief because, oh my God, I'm not the only one with this. And especially in the younger patient, think, oh my God, I'm only 40-something years old. Why would I have this?
And it's very common. And I put that in my book. So go ahead and pick up a copy of I Married a Urologist, because I had to learn about all these subjects too. And when you have fine doctors like Dr. Ruiz here who know about your problem, can fix your problem, pick up the phone and call Dr. Ruiz. And I want to thank you today for being on the show and sharing all that you know, or half or a little bit about what you know about urology, and helping me to get the message out to people that you can get your urological problem solved. It's why I wrote the book, because we don't have these conversations, and we need to start having these conversations so that you can get your quality of life back, get back with the ones you love, get out, go do your sports and shopping and hang out with friends and family. You don't have to isolate. You don't have to be embarrassed. There's help for you. So Dr. Ruiz, thank you for being here today. Thank you for sharing a little bit about what you know, and I look forward to inviting you back.
It's been my pleasure, and I'll be happy to come back.
Oh, thank you. Thank you, everybody.
Thank you for listening to I Married a Urologist with Madeline Zech Ruiz. Please push the subscribe button below the screen and leave us a comment. For more information on urological questions, feel free to contact us through our website, www.imarriedurologist.com. And be sure to catch our next fun and educational episode on all things urology.